Shiva Madhyana, everybody. Good afternoon. I welcome you all to the 12th session of Shalya Tantra and Tadvidya Sambhasha Parishat. Before we start today's session, we will start it with a prayer. Om Namami Dhanvantarim Adidevam Sura Surair Vandita Pada Padmam Loke Jararubhaya Mrutyunasham Dataramishan Vividaushadhina. Welcome back again. So until 11 sessions till today, we have seen different aspects of fractures. We saw different aspects of the spine, diseases of the spine. We also dealt with infections of the bones, that is the osteomyelitis. So today we will be deviating on a new topic apart from all of these. So that will be today. We are going to start the topic on gallbladder. So this session and a couple of sessions we will be dealing with diseases of the gallbladder. What are the different pathologies we are going to see that is afflicting the gallbladder, the basic anatomy and relevant anatomy, physiology of the gallbladder, and all of that. So let us start with the session. So as the usual procedure. So we will start any of the fresh topic. We have always seen starting it with the relevant anatomy, which is very, very important for us to understand the further pathology. So even today, we are going to deal with the anatomy, relevant anatomy, surgical anatomy, and the physiology of the gallbladder, which will help us not in very much detail, but a brief description of the anatomy, which helps us to understand the further pathologies easily. So first of all, we will start with the relevant anatomy of the gallbladder and the biliary tree. So, as all of us know, few important things about the gallbladder before we actually look into the diagrammatic representation of it is that, so we know that GB is situated in underside of the liver. Okay, especially at the junction, near the junction of the right and left lobe of the liver. So it is near to the junction of the right and left lobe of the liver. That is the underside of the liver. The next important thing, as all of us know, is that gallbladder is a it's a pear-shaped organ. Now, another thing what important or very common for us to know is the length and the capacity of the gallbladder. So the length varies somewhere between 7.5 centimeter to 12 centimeters. And its capacity is 35 to 50 ml. So this is the basic. Another important thing what we have to know is that the muscle coat the fibers are arranged in a crisscross fashion. They are arranged in a crisscross fashion. So the body of gallbladder, it has 4 parts. I mean the morphology, the fundus, body, neck, and then not exactly classification, it's the infundibulum, that is the terminal part of the neck. So we have the fundus, body, neck, and the terminating part from the neck further on, that is the infundibulum. Actually, mainly it is 3, that is the fundus, body, and neck. Another important thing, or what we have to know, is about the crypts of Lushka. So, what is crypts of Lushka? So, as we know, we have the muscle fiber, we have the muscle layer, and what we have, the next is the mucosal layer. So this mucosal layer, what is crypts of Lushka is that at certain places in the body of the gallbladder, we have this mucosal layer that sinks inside towards the muscular coat. So they are found as indentations actually. Indentation in the mucosal coat. So at many places, this mucosal layer, it dips into the layer of the muscular coat, and those indentations are called as crypts of Lushka. So this is just a brief introduction of it, that it is situated on the underside of the liver. So it's a pear-shaped organ which is 7.5 to 12 centimeter of variation in its length, and its capacity is about 35 to 50 ml. So we have the main three parts, that is the fundus, body and the neck, the further continuation as the infundibulum. So the muscular coat is arranged in crisscross fashion, and crypts of Lushka, wherein at certain places the muscular coat, it dips into or it moves into the muscular coat, forming that causes indentations at the mucosal coat. So that is called as crypts of Lushka. Okay, now moving on further. So we have okay. So here we have the liver. A gross representation of the diagram. So we have the right hepatic duct, we have the left hepatic duct that joins to form the common hepatic duct, and then we have the cystic duct that joins the common hepatic duct that forms the common bile duct. So further we have, so here we have the duodenum. Okay, so we shall name them as we told. So we have the right hepatic duct, we have the left hepatic duct that forms the common hepatic duct. So from the gallbladder we have the cystic duct. Cystic duct and the common hepatic duct confluences to give rise to common bile duct. Now, here what it is important with respect to the common bile duct is that common bile duct has 4 divisions. So what is that? So here we know that here this is one portion of the common bile duct. We have the duodenum. So the common bile duct is running behind the duodenum. It is coming down to enter the second part. So here what we have another part which runs behind, and we have another part which is below the duodenum, and we have another part which is just entering the sphincter to enter and to move inside the duodenum proper. So what we can name all of this is that, so first we have 4 divisions. So the first one, supraduodenal. So the next from behind we have retroduodenal. The next, this part, it is the infraduodenal, and this is inside. So this is intraduodenal part of common bile duct. So this is the basic of representation of the biliary tree. So now seeing on of each of this. So first we have, let us see about the cystic duct. So this cystic duct, it is almost 3 centimeters in length, varies, and about 1 to 3 mm in diameter. 1 to 3 mm in diameter. So, and inside this part of the cystic duct, we have something with special with respect to the mucosa of the cystic duct. So, inside here, the mucosa is arranged as spiral valves, and that spiral valve is called as valves of Heister. So this is with respect to the cystic duct, that is the dimension. So it is 3 centimeter in length, around 1 to 3 mm in diameter, and the mucosa inside the cystic duct, it is arranged as spiral valve, valvular form, and that is called as valves of Heister. Now another important thing what we have to know with respect to the cystic duct is that there could be variations that are occurring here. One is the cystic duct joining the common bile duct in the supraduodenal part. So this happens, cystic duct to the supraduodenal part of CBD. So this is common in 80% of the cases. The normal anatomy is that the cystic duct joins the common bile duct at the supraduodenal part. Now, if this is 80%, what is rest that the variations could be? So another possibility is that this cystic duct, it joins the common bile duct at the retroduodenal part of common bile duct. Even this could happen. Now, what is another variation that could happen is, now first one we saw, it could join with the, that is the retroduodenal part of the common bile duct. Another possibility is that the common bile duct joining the right hepatic duct, and in some cases the cystic duct, not the common bile duct, the cystic duct joining the right hepatic duct, or the cystic duct, even in some cases it joins inside to the right sectorial hepatic ducts too. So even all these three are the variations how the cystic duct could join to the common bile duct. So to the common bile duct, it can join in 2 places, supraduodenal and retroduodenal. Apart from that, the cystic duct could also have a confluence with right hepatic duct or the right sectorial ducts too. So this is the variation with respect to cystic duct. Now we move on further now with respect to the common hepatic duct. So we will see what are the dimensions for the common hepatic duct. So now the common hepatic duct, it usually this is usually 2.5 to 3 centimeter in length. That is the common hepatic duct. So it is formed by the confluence of the right hepatic and the left hepatic duct. Now further we move on with respect to the common bile duct. So with respect to common bile duct, we have already seen that this common bile duct it is around 7.5 centimeters in total, 7.5 centimeter in length in total. So this is formed by joining of the cystic duct and the common hepatic duct. And this CBD, that is the common bile duct, has 4 divisions. That is the supraduodenal, the retroduodenal running behind the duodenum. We have the infraduodenal running below the duodenum, and then we have the intraduodenal, which is entering into the duodenum at the lower end. So these are the 4 parts of the common bile duct. Now another thing here is, so what is the with respect to the blood supply, the arterial supply is by the the arterial supply is by the cystic artery, which is a branch of the right hepatic artery. Okay. At some times, apart from cystic artery, you also have an accessory cystic artery. This is the branch of the gastroduodenal artery. So this is the branch of the gastroduodenal artery. Now, in 15% of cases, what happens with this is, there is also a variation with this, is that the cystic artery could pass in front of the common hepatic duct and the cystic duct. So in such cases, it is very, very difficult while we are performing a surgery wherein there is inflammation around the cystic duct. So in such cases, especially in laparoscopic approaches, which is very commonly done nowadays, so this part is very, very important to take care not to injure the cystic artery in such case of variations in 15% of patients. So in 15% of people, not patients, it could be a normal anatomy in many people in 15% of people. So where the cystic artery passes in front of the common hepatic duct and the cystic duct. Okay, so in such cases, the operative procedure has to be done very, very carefully and with great care. Now, further now we move on to, so this is another thing with respect to the lymphatics. What we have to see is that here where in the, where the cystic duct and where the common hepatic duct joins, so at that place we have the lymphatics. So basically the subserosal and the submucosal, it drains to what is called as the node of Lund. So here, so the first thing is the node of Lund. This is also called as the sentinel node for this drainage. From there again, the efferent vessels from the node of Lund, it drains to the celiac nodes and subcapsular nodes. So from the node of Lund, we have the lymphatics that is draining to the celiac nodes and the subcapsular. So few of it also actually gets drained to the hilum of liver too. So this is with respect to the lymphatic drainage. So here now we saw the right hepatic duct, the left hepatic duct. Then we saw the common hepatic duct, its length. We saw few information on cystic duct. We saw what the common bile duct is. We saw 4 parts of the common bile duct. Then we also saw the variation with respect to the attachment of the cystic duct. Then we saw the arterial supply and variation with respect to that. And next it is the lymphatic drainage. So this is in brief about the biliary tree. So for this we have already seen the variations, that is the fundus, body and the neck, and further the infundibulum. So this is with respect to the gallbladder. Now further, seeing the little information on the composition of bile and what are the functions of bile as a part of normal physiology. So first we will now see what bile is composed of. So bile is composed of 97% of water, 1 to 2% of bile salts, around 1% of bile pigments, cholesterol and fatty acids. So this is the normal composition of the bile. Coming to with respect to the liver excretion, the rate of liver excretion of bile. Okay, so this is around 40 ml per hour. So it is at this rate that always the bile gets excreted from the liver. Now, with respect to the secretion of bile from the gallbladder, it is actually managed by CKK, that is enzyme of the duodenum, which is called as cholecystokinin. Now, this is present in the mucosal layer of the duodenum. So, with respect to the content of food that is being taken, this influences how much of bile gets secreted from the bile that is storing the excreted bile from the liver. Now, suppose when there is during the periods of fasting or when there is no food, what happens? So, we have the sphincteric mechanism from the sphincter of Oddi. So, what we have seen the biliary tree previously. So, it ends. Suppose if this is the duodenal part, which is entering. So, suppose during fasting, what happens? When there is no food, when there is no bile required, then the resistance of this sphincter of Oddi, it increases. And when this resistance increases, then what happens? The bile that is coming here, secreted from the liver, it is not let inside and it gets stored inside the GB. When during the period of no food or during the period of fasting, when bile is not necessary. When there is food, when there is food coming inside or after lunch, post the lunch, what happens? This resistance from the sphincter, it decreases. So then what happens? The bile, the gallbladder, it contracts and it facilitates the flow of bile into the duct, that is into the common bile duct and further down into the duodenum. So this is how the basic response of cholecystokinin with respect to the bile that is stored inside the gallbladder. Okay. So the next thing what we have to see is with respect to the functions of gallbladder. So on a whole, briefly we can say that gallbladder has three important functions. So they are, first is to store the bile or storage of bile. So this is the first one. Now, the next thing is to enhance the concentration of bile. And the third one is with respect to mucus secretion. Now, as with respect to the storage of the bile, just now we saw that when bile is not necessary, where does all the bile that is getting excreted get stored in? It gets stored inside the gallbladder. So that is how it functions with respect to the storage of bile. Now, next is with respect to the concentration of bile. Now, what is with respect to the concentration of bile, or how the gallbladder aids in concentrating the bile? So, usually to whatever the bile comes to whatever it stores, the bile is concentrated into 5 times. So, how is that? Because there is active absorption of the water content, the sodium chloride and the bicarbonate. And the water content. So active absorption keeps on going by the mucosa of the GB. This is by one method. And the next thing how it increases is that it also increases the proportions of the bile salts, bile pigments, the cholesterol and the calcium. So we know that what was the percentage normally. So that is with respect to the stored bile. But here with respect to the excreted bile to what is being stored, the gallbladder increases the concentration of the bile. One is by absorption of this, and then is by increasing the proportion of the bile salts, the bile pigments, cholesterol and calcium. So by this, it increases the concentration of the bile. Now, the next thing is with respect to mucus secretion. So, gallbladder also has a role to play with respect to mucus secretion, that it secretes around 20 ml of mucus secretions of mucus per day. Okay, so on totally briefly, we could see that these three are the functions of the gallbladder. So now we saw, after the anatomy, we saw what are the contents of bile, and then we saw how it is, the excretion happens at what rates, and how it is being stored in the gallbladder. And next we saw the main three functions of gallbladder 2. Now, further with respect to these gallbladder, let us move on with a different route or fashion, is that before we start into looking for about the pathologies in detail, we will see a short, brief explanation on what are the relevant investigations that are to be done with respect to the gallbladder, and which investigation actually helps you to focus on which part relevant anatomy or the pathology of the gallbladder. So when we know that, further on when we actually deal with cholelithiasis, choledocholithiasis and all of that, it is very easy for us to understand as why that particular investigation is being done in that particular pathology. So now moving on to the radiological investigations of the biliary tract. Okay, now the first one, we'll see it in very brief as much as possible. So the first one is the plain radiograph. Okay, now what is this plain radiograph, and how much can this plain radiograph, that's an X-ray, could pick up with respect to the gallbladder pathology? So the plain radiograph only picks up around 10% of gallstones. Why? Because only 10% of gallstones are radio opaque. Okay, so the others are not, and they are not picked up by unusual. That is the basic radiograph, that's an X-ray. So only 10% of gallstones that are radio opaque are captured by this X-ray. Another thing what this plain radiograph could also visualize is that in certain cases within the gallstone, so inside there is something called as a radiolucent gas. So within the gallstones, few of the gallstones, there is lodging of the radiolucent gas is being inside, all it is like almost as if it is being captured inside. So that usually it is in the biradiate and the triradiate fashion. So when a radiograph is taken on that, so this portion appears as bright thing on the plane, that is the radiograph. So with this, it also gets another name, that is Mercedes-Benz sign or the Seagull sign. So it is also called as the Mercedes-Benz sign or the Seagull sign. So this is because of that is a gas that is captured within it, that is forming to cause the bright bright appearance on the X-ray film. So that is because that is captured as in the form of a triradiate and a biradiate fashion. Now, what is the next thing that the X-ray could pick up? So the next thing is, only in certain cases, the X-ray will also show the calcification of gallbladder. Okay. So in this cases, what it suggests, suppose if there is calcification that is being seen, then it suggests that there is also an association of Ca with the existing pathology. There is a doubt for association of a cancerous lesion that could want you to remove the gallbladder as a whole, depending on the pathology. So these are few things what a plain radiograph with respect to gallbladder can pick up. Now the next thing is ultrasonography, that is the USG. That's the ultrasonography, the USG. So what all it shows? So if the GB wall has thickened, it gives a light on that. It gives the dimension of the CBD, whether there is an increase in diameter suspicious of a stone lodging inside that. So it also gives an information on the CBD dimensions. Another thing, it also helps you to show if there is inflammation present around GB. If there is inflammation present around GB. In certain cases, it is also actually helpful in CA pancreas, that is actually occluding the common bile duct. Occluding the common bile duct. So we have, it shows the thickened wall of gallbladder. Suppose if there is presence of any inflammation, and the size of common bile duct, that is, as we have seen here, that is the dimension of the common bile duct. And very important, in cases of obstructive jaundice, it helps you to identify the intrahepatic and the extrahepatic strictures and also dilatations. Both intrahepatic and extrahepatic, especially in cases of obstructive jaundice. So in such cases, it also helps you to visualize all of this. That is the intrahepatic and the extrahepatic. Even though if it is because of any strictures or whether if there is any dilatation, all of them are picked up by the USG. Now the next thing is the EUS. That is endoscopic ultrasonography. So what is this? This is nothing but an endoscope plus ultrasound transducer at its tip. So what it helps you to visualize is that it visualizes the liver, the biliary tree from within the stomach and the duodenum. So how it is going to visualize? Actually, we know that we now know the biliary tree, how it ends into the duodenum. So with respect to, we enter through the stomach, we enter the duodenum, and then we move into the sphincter, we enucleate the sphincter, and then we move into the duct, and then we try to visualize the common bile duct. So through the stomach and the duodenum, we are trying to visualizing the biliary tree. So with respect to EUS, what all it can pick up is that, so first of all, it gives an accurate imaging of the common bile duct. Why? Because we are through the duodenum. So here we have the common bile duct that is connecting, right? So we saw the biliary tree previously. So through that we are visualizing the common bile duct. So it picks up clear anatomy of the common bile duct very accurately. So in such cases, EOS is used. Another thing where EOS plays very important, that is with respect to whatever we discuss now, is with respect to choledocholithiasis. It is with respect to choledocholithiasis, that is the gallstone in the common bile duct, that is choledocholithiasis. So obviously when we see into the bile duct, we can get to know all the features of where the stone is lodged, what is the size of the stone, everything is being picked up by the EOS. Another thing is this, since it is very close here at the pancreatic lesion, it also helps you to pick up lesions of the pancreatic CA and the periampullary CA. So this is how EOS helps. So suppose in certain cases what happens, actually EOS can also be used to remove the stone also. As a therapeutic, if there is no impaction, then if it is easy to remove, it can actually be removed through EOS. So we have the common bile duct. So we have So this is the retroduodenal part. So we have it here, the duodenum here. So through the from the stomach and the esophagus, a scope is passed here. That comes into the not here. Okay. So through this we enter the common bile duct. There is something called as Dormia baskets that are used to remove the stones from within. So with that, suppose you are able to access it. So there is a procedure with this wherein another stent moves inside, and there once it moves above the stone, suppose this is the stone, once it moves above the stone, then you open the Dormia basket. So it is like as if you are catching the stone in a net, and then it is pulled down carefully and it is taken out. So it is also used as a therapeutic purpose also. So this is with respect to the EUS. Now the next thing is radioisotope scanning. So this is done using Tectinium 99. So what it actually does is, so this is inserted intravenously as a dye. So some parts of this Tectinium dye that will be taken up by the cells of the liver, that is the reticuloendothelial cells of the liver. Okay, they will be taken and they will be excreted along with the bile, that is in the bile. Okay, so now we have this dye injected which will be taken up by the cells of the liver, and that will be also secreted along with the bile that is being excreted from the liver. So obviously what happens now, once the IV is the drug is being injected, maybe between 30 minutes to 1 hour, the dye will start getting excreted, and when it start getting excreted, you start taking films, so that wherever the dye is moving along the biliary tree, it is being seen as a radio opaque part, so you are able to visualize the entire biliary tree. So suppose now what happens, even after 30 minutes to 1 hour, you are not able to see how the bile is going and filling the gallbladder. If the gallbladder opacity is not seen, you are not able to visualize gallbladder, then it means that there is acute inflammation there. That is, there is cholecystitis there present. So that is a suspicion. Acute inflammation is present. Now suppose you are able to see it, but it is very, very delayed. Then what it says that almost that the GP has gone for a complete contraction because of maybe many episodes of cholecystitis, that is the chronic cholecystitis. That is because of chronic cholecystitis. Another thing what we could be assessing here with respect to the radioisotope scanning is that with respect to the bile leaks, usually after the OT, when the gallbladder is removed off after cholecystectomy, so this when you have a suspicion of bile leak, which is very, very important to be taken care of, otherwise leads to an emergency. So this when you are suspecting a bile leak to happen in post-operative times, even then they go for a radioisotope scan. So this is with respect to that. Now the next imaging criteria is the CT. So how CT helps with respect to pathologies of gallbladder. Now one important thing what we have to know, that is CT actually visualizes the liver, bile ducts, gallbladder and pancreas, all of them. Okay, but usually CT is more helpful in detecting the hepatic and the pancreatic lesions. With respect to GB, that is gallbladder, CT it is not helpful for any of the benign lesions. it will also not help you much with respect to the gallstones and the inflammation also. That is cholecystitis. So with respect to these, CT will not give any much accurate information. So where actually CT chance holds as a modality of choice is that, especially in staging the CA and to know the extension of invasion. So in such cases, CT holds as a choice of modality. It could be CA of the liver, when of the GB or of the bile duct. The pancreatic end, all of this when there is a malignant lesion. So then usually CT is of help. To be remembered that usually it is not taken as a choice of modality for benign lesions of the gallbladder or the biliary tree. Now the next is MRCP and ERCP. Okay, so as MRCP says, it is nothing but with respect to the principles of MRI, that is magnetic resonance imaging. So you have magnetic resonance, we have the endoscopic retrograde cholangiopancreatography, and we have the magnetic resonance cholangiopancreatography. So priorly ERCP was considered as the gold standard for the diagnosis of the gallbladder or the biliary tree regions, but currently ERCP, that is endoscopic retrograde cholangiopancreatography, as I told you, with respect to the removal of the stones or placing the stent, all of that is possible with ERCP. So it also gives you a diagnostic measure. During the process of diagnosis, after a confirmed diagnosis, the same can be used as a part of treatment also. So currently ERCP is done because it's an interventional method. It is done only when you want a therapeutic action. Only then ERCP is done. MRCP with respect to the MRI principles, currently this is considered as the gold standard. So it picks up all required details with respect to the gallbladder and the biliary tree without actually intervening into the patient and without causing no much potential harm to the patient. So any form of stricture, any form of dilatation, or also the detailed anatomies, even the ductal abnormalities, all of them are picked by the MRCP. So with respect to endoscopic retrograde cholangiopancreatography, so we already saw that. So with how it is done previously, the same explanation with respect to the Dormia basket and removal of the stone. So here, as a part of diagnostic, what they actually do is that, so it uses a side view endoscope. So here what they do is that once the ampulla of Vater is identified through while passing through the stomach and duodenum, they go inside, they nucleate through that is the ampulla of Vater. The next thing what they do after that is that's the injection of the water soluble contrast directly into the bile duct. So once you are inside the bile duct, so they inject the water soluble contrast. So with that, what we can do is that once the water soluble contrast fills up the common bile duct through the ampulla of Vater, after moving through the ampulla of Vater, you are able to, when the films are taken again, you are able to visualize the entire biliary tree, that is the common bile duct. So this will also give you an evidence of the stones. Suppose if there is stricture present in the bile duct, suppose if there is stricture in one part, so this stricture is also identified. Suppose if there is stone inside the common bile duct, that is also identified with ERCP. This is with respect to only the diagnostic aspect. Now there is something called as PTC, that is called as percutaneous transhepatic cholangiography. Percutaneous transhepatic cholangiography. pancreatography. So here what is done is that through the skin, that is through the cutaneous route, the liver is entered. So inside the liver, through the duct, they enter either the right or the left. Then they come to the common hepatic duct, and finally they enter into the common bile duct. So it is through the external route that you are under the fluoroscopic contact. So all of this is done under strict precautionary measures. Patient is advised, he is given a course of antibiotics preoperatively, and all of this is done under fluoroscopic guidance. So when actually the scope is inside the common bile duct, then a needle is passed. So a needle, usually it is called as a Chiba needle. So whatever is the needle we use to move from the skin. So it has many types of needles are used. So there is also called as Okuda needles. So these are very fine needles that can be used to move through the tiny structures of all these ducts. So once they're inside, again, as we saw with respect to ERCP, here also a water-soluble contrast medium will be injected. So once you are in the duct and you are injecting water-soluble medium, so again, when you take out the films, you are able to visualize the biliary tree. So suppose if there is obstruction at any place, suppose there is stricture at any place, all of that is done. So actually here it is just a brief explanation. All of this has varied amount of usage with many pathologies. So when we move on to different pathologies, whenever there is need of all these investigations, we will see it in a little bit detail. So actually this PTC is also used in draining of the common bile duct in case of stricture and when there is collection of bile. So it is very important for us to remove the bile out of there, because it is called as decompression actually. So where you are removing out of the stasis of the bile. So in case of decompression also PTC is used. Now suppose if there is a stricture in common bile duct, you want to dilate it. So using this PTC, you can, or they also place stents here so that the common bile duct is, it is made dilated over a period of time. Suppose during the procedure you are not able to dilate, there is also an option to leave a drainage with the help of a catheter and a drainage too. So whatever is the collection that is being drained, and when the stent is placed inside for a long time, so the stricture could be waved off, or that part could be dilated. So these are all interventionary and investigations that are to be done in strict aseptic measures and under strict control. So this is with respect to the radiological investigations. Apart from this, there is also what is called as peroperative cholangiography, and you also have operative biliary endoscopy. So that is done during the OT. Like suppose when during an open surgery or during a laparoscopic cholecystectomy, so we use peroperative cholangiography and operative biliary endoscopy. So these are two investigations that are usually done during the operation. Suppose in case of doubt, so you want to assess the exact place of pathology. So in various procedures, these two are done. So basically, this was with respect to the investigations, what we do for diagnosing a pathology in the biliary tree and with respect to the gallbladder. So today we saw the basic of a relevant anatomy in very brief. And we saw what the physiology, the main three functions of gallbladder. Then we saw all the investigations that we could do for assessing the pathology of the biliary tree. So we saw what a plain X-ray could do, what it could assess. We saw what USG could assess, endoscopic ultrasonography. We saw MRCP, ERCP. We saw PTC and all of that. We also saw radioisotope scanning. So with respect to this basic details, further on when we move on with particular pathologies, maybe in other 2 sessions, then we will see in a little more detail. It becomes easy for us to understand why that particular investigation has been picked up in that pathology. Now saying so, I would like to conclude today's class again with a small prayer. Om ज्ञानानन्दमयं देवं निर्मलस्फटिकाकृतिम् आधारं सर्वविद्यानां हयग्रीवम् उपास्महे। ॐ शान्ति शान्ति शान्तिः. Thank you. See you again in the next session.